Welcome to the Deep Dive, where we cut through the noise and distill complex topics into essential knowledge, giving you that shortcut to being truly well-informed. Today, we're embarking on, well, a really fascinating journey into one of the most mobile and intricate parts of the human body, the shoulder.
Yeah, it really is intricate. We've compiled a stack of detailed sources today covering pretty much everything from the foundational anatomy of your shoulder girdle
Okay.
right through to the really precise techniques medical professionals use to actually see inside it. Our mission today is to unpack these insights, helping you grasp not just what the shoulder is made of, but also the clever ways we can visualize its inner workings, piece by piece.
Get ready for some genuinely surprising facts about your own body's engineering, I think,
Yeah.
and a real eye-opener on the precision involved in medical imaging. Okay, let's unpack this.
Okay.
So let's start right at the beginning. When we talk about the shoulder, well, we're often simplifying things a bit, aren't we?
We definitely are.
We're actually diving into what's called the shoulder girdle, which isn't just one bone, but more like a dynamic duo, the clavicle and the scapula.
That's exactly right. Think of the clavicle as your collarbone, and the scapula, well, that's your shoulder blade. Their primary role is pretty fundamental. They form the crucial connection between your arm, your upper limb, and the main trunk of your body.
Okay.
And what's particularly fascinating is how they articulate, how they join together. So the shoulder girdle connects outwards, laterally, with the head of the humerus, that's your upper arm bone, at what we just call the shoulder joint.
Right.
And then it connects inwards, medially, towards your chest, with the manubrium of the sternum at the sternoclavicular joint,
The SE joint.
or SE joint, yeah, for sure.
So the humerus, the long bone in your upper arm, isn't technically part of the girdle itself,
No, technically not.
but it's clearly a vital player. Why is its role so important when we're, trying to understand the shoulder?
Well, because its top portion fits directly into the shoulder girdle, its proximal anatomy, that's the upper part, is absolutely critical when we're looking at images of the shoulder joint. Can't really separate them visually.
Makes sense.
And the shoulder joint itself, it's quite a marvel of engineering. It's a synovial ball and socket type joint.
Like a golf ball on a tee, kind of?
Exactly, yeah. Imagine that kind of setup. It allows for an incredible range of motion.
Which is great.
But that mobility also makes it somewhat vulnerable to injury.
Incredible range, but potential vulnerability.
Yeah.
Okay, that makes a lot of sense. Let's maybe zero in on the clavicle first, the collarbone. What makes it unique?
It was a long bone, and it rests just above your first rib. On its outer end, the acromial extremity near your shoulder,
Uh-huh.
it connects with a part of the scapula called the acromion, forming the AC joint, acromioclavicular.
Okay.
On its inner end, the sternal extremity near your sternum, it connects to that manubrium part of the sternum we mentioned.
Yeah.
That forms the SC joint.
Right.
What's really interesting about the clavicle shape is its distinctive double curve. It's almost like a gentle S shape.
Oh, really?
Yeah, and that curve is often a bit more pronounced in males than in females.
Huh. So it's not just a straight stick. And then we have the scapula, the shoulder blade. I imagine this one is a bit more complex in shape.
It definitely is. The
Yeah.
scapula is a flat, triangular bone that sits on your back, forming the posterior or back portion of your shoulder girdle. It has two main surfaces, a front surface, the costal surface that faces your ribs,
Okay.
and a back surface, the dorsal one that you can, feel under the skin. It also has three distinct edges or borders: lateral, medial, and superior.
And these angles and borders, what did they tell us? Or why are they important to map out for, say, imaging?
Well, they form key landmarks. You have three angles where these borders meet. But the most critical part, functionally, is probably the lateral angle.
The lateral one.
Yeah, it's the thickest part of the scapula, and it ends in this shallow, kind of cup-shaped depression called the glenoid cavity, or glenoid fossa.
Ah, the socket part.
Exactly. This cavity is key because it's the socket where the head of the humerus, your upper arm bone, truly connects. This forms the glenohumeral joint, which is really the proper name for the actual shoulder joint itself.
So it's that glenoid cavity that gives the shoulder its famous ball and socket action. Got it. Are there other distinctive features on the scapula that professionals look for, like bumps or points?
Absolutely. The scapula has a couple of very important bony projections or processes. There's the acromion.
The one that connects to the clavicle.
That's the one. It's that long curved process that extends laterally over the head of the humerus. It's the bony point you feel at the very top of your shoulder.
Right.
Then there's the coracoid process. This one's a thicker, sort of beak-like projection that sticks out anteriorly or forward from beneath the clavicle, and there's also a little notch, the scapular notch, on the superior border. Understanding these landmarks is crucial because they act as guides, not just for understanding the anatomy, but for accurately positioning patients during imaging procedures.
Okay, so we've got this amazing, complex anatomical structure, clearly designed for incredible mobility. But sometimes things go wrong, or we just need to understand what's happening inside. So how do medical professionals actually see these intricate structures without, cutting you open?
Right.
That's where the art and science of radiographic procedures come in, I assume.
Precisely. And before any imaging even begins, patient preparation is vital.
Okay.
This is mainly about ensuring a clear picture. So that means removing anything that might block the X-ray beam or create artifacts on the image.
Like shadows or bright spots where they shouldn't be.
Exactly. Things like jewelry, bra hooks, buttons on clothing.
Yeah.
These are called radiopaque items because they block or absorb the radiation and can obscure the anatomy we need to see.
Right, makes sense. And patient comfort must be a big factor, too. I imagine getting into some of these positions isn't always easy, especially if you're in pain.
You're absolutely right. Comfort is paramount. Shoulder procedures can often be performed with the patient upright, standing or sitting, or recumbent, meaning lying down. It really depends on their condition, their comfort level, and the specific view the radiologist needs.
Okay.
And for the imaging itself, a couple of standardized parameters are really essential. There's collimation.
Collimation.
Yeah, which basically means defining the exact area the X-ray beam will hit. Kind of like focusing a spotlight very precisely onto just the area of interest.
Got it. Minimizing unnecessary radiation, too, I guess.
Exactly. And the other is SID, or source-to-image receptor distance. That's just how far the X-ray source is from the detector or film. For most shoulder, clavicle, scapula, and AC joint procedures, that distance is typically standardized at 40 inches, or about 100 centimeters.
Okay, standardization helps compare images, I suppose. What about instructions for the patient? Do they need to hold their breath or something?
Yes, clear instructions are key. For most exposures, patients need to suspend their breathing, just hold their breath for a brief moment.
Why is that?
It minimizes motion, which prevents blurring and gives us a much sharper image of the bones.
Ah, okay.
But here's where it gets really clever. For certain views, like one called a transthoracic lateral projection.
Transthoracic, through the thorax.
Exactly. It helps you see the shoulder through the chest, which is useful in trauma when the patient can't move their arm out of the way. For that view, a special breathing technique might actually be used.
Breathing during the X-ray.
Yeah. It involves using a low radiation setting, a low MA, and a longer exposure time. This allows the natural, gentle movement of the lungs during breathing to actually blur out the ribs and other lung structures you don't want to see clearly.
Wow.
It makes the shoulder structure stand out much better against that blurred background. It's about using motion artifact to your advantage.
That's a brilliant technique, using the body's own movement. Okay, so let's get into the specifics of essential projections for the shoulder joint itself. We know it's a ball and socket, capable of all sorts of motions. How do we capture it best?
Well, we often start with what's called an AP, or anteroposterior, projection of the shoulder. That means the X-ray beam goes from front to back through the patient.
Okay, standard front view.
Right. But what's fascinating is how we can subtly change the arm's position within that AP view to reveal different aspects of the shoulder anatomy. We might image the arm in internal rotation, external rotation, or just a neutral position.
So 3 variations of the front view. What does each of those different arm positions reveal specifically?
That's a great question. They each highlight different bony landmarks. So for internal rotation, the patient rotates their arm inwards, usually resting the back of their hand on their hip. This specific positioning places the humeral epicondyles, those bony points at the elbow, perpendicular to the image receptor.
And what does that show us?
It brings a specific bump on the front of the humerus, called the lesser tubercle, clearly into profile, pointing medially towards the body. The greater tubercle gets superimposed over the humeral head. It's good for looking at that lesser tubercle specifically.
Okay. What about external rotation?
Here, the arm is rotated outwards, usually with the palm facing up or forward, so the epicondyles are parallel to the image receptor. This view, in contrast, shows another bony prominence, the greater tubercle, clearly in profile on the lateral or outer aspect of the humerus. It also gives us a good profile view of the humeral head itself. It's a really key general assessment view.
So internal shows the lesser tubercle, external shows the greater tubercle.
Got it.
And the neutral position.
This view is particularly useful for trauma cases, when the patient can't easily move or rotate their arm due to pain or injury. The epicondyles end up at about a 45-degree angle to the receptor.
A sort of middle ground.
Exactly. The greater tubercle is partially seen, partially overlapping the humeral head. It offers a general look at the shoulder with elements of both other views, but without requiring potentially painful rotation. Each subtle rotation really provides a unique diagnostic window.
That makes perfect sense. A different view into the joint depending on what you suspect or need to see clearly. What about a view that aims to specifically open up that glenohumeral joint space, the actual articulation?
Yes. For that, we use the AP oblique projection, often called the Grashy method.
Grashy method, okay.
This projection is specifically designed to get an open, unobstructed view of the joint space between the head of the humerus and the glenoid cavity of the scapula.
How is that done?
The patient's affected shoulder is positioned closer to the image receptor, and their whole body is rotated slightly backward into about a 35 to 45 degree posterior oblique position. The goal is to carefully rotate the patient just enough so that the flat surface of the scapula becomes parallel to the image receptor.
Aligning the scapula flat against the detector.
Precisely. And when done correctly, you get this beautiful, clear view of that open joint space with the glenoid cavity seen perfectly in profile, like a little shallow dish.
That's really clever, using body rotation to literally open up that visual window. Now, for those trauma patients we mentioned, the ones who can't rotate or even lift their arm, you mentioned the transthoracic lateral projection earlier. How does that help again?
Right, this is often a lifesaver for immobile patients. The injured arm stays close to the image detector, ideally resting by their side. The uninjured arm is then elevated, lifted up over the head.
Okay.
It's crucial not to move the injured limb while doing this. The X-ray beam then passes through the patient's chest, the thorax, from the uninjured side to the injured side.
I see. Aiming through the chest cavity.
Yes. This allows us to project the injured shoulder and the proximal or upper humerus clearly right through the lung field. And remember that special breathing technique we talked about?
The slow breathing during exposure.
Exactly. Slow, deep breathing during the exposure, often for at least 3 seconds, helps blur out the distracting ribs and lung markings. It gives us a surprisingly clear lateral view of the shoulder joint, even with the chest structures technically in the way. It's a fantastic example of adapting the technique the patient's limitations.
Really is. Okay, another scenario. Dislocations. Is there a particular view that's considered sort of the diagnostic superpower for figuring those out?
Absolutely. One of the most common and I'd say powerful projections for diagnosing shoulder dislocations is the PA oblique, which is better known as the scapular Y projection.
Scapular Y. Why Y?
It's called the Y view because the way the bones overlap on the image creates a distinctive Y shape. The top arms of the Y are formed by the eccrine process posteriorly and the coracoid process anteriorly.
Those two projections we talked about earlier.
Exactly. And the vertical stem of the Y is formed by the main body of the scapula.
Okay, I can picture that. And how do you interpret that Y for dislocations? This sounds like it could be a real aha moment for diagnosis.
It truly is. The patient is usually standing or sitting with the front of their affected shoulder turned toward the image receptor in about a 45 to 60 degree anterior oblique position, RAO or LAO, depending on the side. The key is to position them just right, often by feeling the scapula, so that the flat body of the scapula is perfectly perpendicular to the image receptor plane.
Perpendicular this time, not parallel like the Grashy.
Correct. Now, in a normal, healthy shoulder, the head of the ball of the joint, should be perfectly centered right over the intersection of that Y, where the 3 limbs meet.
Okay, centered is normal. So what happens in a dislocation?
Here's the diagnostic power.
Yeah.
If the humeral head is seen projected below the coracoid process, the lateral arm of the Y, that indicates an anterior dislocation. The head is popped out forward and usually downward, and this is the most common type of shoulder dislocation by far.
Okay, below coracoid means anterior.
Right. Conversely, if the humeral head is seen projected below the acromion process, the back arm of the Y, that points to a posterior dislocation, where the head is popped out backward. Much less common, but important to identify.
Wow. So that single view can tell you not just if it's dislocated, but crucially which way it's dislocated.
Exactly. Which is vital information for the doctors deciding how to reduce it, how to put it back in place. It's a really elegant and informative view.
Definitely sounds like it. Okay, moving slightly beyond the main shoulder joint itself. What about imaging those other components of the girdle we discussed earlier, like the AC joints?
Right, good point. We also have essential projections for those structures too.
So starting with those AC joints, the acromioclavicular joints, where the collarbone meets the shoulder blade, What's the standard approach for looking at those, especially for separations?
For AC joints, we typically perform an AP bilateral projection. Bilateral meaning we image both joints, left and right, at the same time for comparison.
Makes sense. Compare sides.
And here's the critical part.
Mm.
We almost always do it with and without weights.
Weights. Why weights?
It's essential the patient is upright for this standing or sitting. Why? Because if they were lying down, gravity wouldn't be pulling on the arm, and any subtle dislocation or separation at the AC joint might naturally reduce itself, and you wouldn't see the true extent of the injury.
Ah, so standing shows the real picture.
Yes. So we make two separate exposures on potentially one large detector or two smaller ones. First, with the patient just standing relaxed, arms unweighted. Then we give them specific weights to hold in each hand, letting their arms hang straight down.
Applying some stress then.
Exactly. That added weight pulls down on the arms and clavicles. If there's instability or a ligament tear at the AC joint, the weighted view will often show a widening of the joint space or the clavicle displaced upwards compared to the unweighted view or the other side. It dramatically reveals a separation that might otherwise be missed or underestimated.
That's really clever, applying a little stress test radiographically to truly see the injury. What about the clavicle, the collarbone, on its own? Are there specific tricks to imaging that long, curved bone?
The clavicle can be a bit tricky. Yeah, mainly because it sits right over the top of the ribs in the apex or top part of the lungs. Overlap is the enemy.
Right.
So we use different standard projections and sometimes angles and breathing techniques to get the clearest view. We typically do an AP view front to back and sometimes a PA view back to front.
Is there a big difference between AP and PA for the clavicle?
The PA view technically might reduce magnification slightly because the clavicle is closer to the detector, but the AP is often faster and maybe a bit more comfortable for the patient. For the standard AP clavicle, the X-ray beam, the central ray or CR, is aimed perpendicular, straight on, to the midshaft, the middle of the clavicle.
Okay.
And the exposure is usually made at the end of exhalation.
Exhalation. Why is that?
Breathing out fully actually lowers the shoulders and the clavicle slightly. This helps to minimize the overlap with those upper ribs and lung tops, giving a clearer view of the bone itself.
So you're using the body's natural movements to your advantage again. Breathing out lowers it. What if that's not enough? What about angles?
Exactly. If we need to project the clavicle even further off the chest structures, we use axial views. Here, the X-ray beam isn't perpendicular anymore, it's angled. For the AP axial clavicle, we angle the beam upwards, a cephalic angle, typically between 15 to 30 degrees.
Why the range 15 to 30?
It depends on the patient's body thickness, their habitus. Thinner patients generally need a steeper angle, closer to 30 degrees, to project the clavicle upwards enough. Thicker patients need less angle.
Okay, tailored to the patient.
Yes. And for this AP axial view, the exposure is made at the end of a full inspiration.
Breathing in this time.
Right. Inhaling fully raises the rib cage and the clavicles, elevating them above the ribs and lung apices. So exhalation for the straight AP, inhalation for the AP axial, opposite techniques for different goals.
Clever. And is there a PA axial too?
There is. The PA axial clavicle involves angling the beam downwards, a caudal angle, again 15 to 30 degrees, exiting the midshaft. Both axial views aim to achieve the same thing. Project at least the lateral two-thirds of the clavicle clearly above the ribs, showing the bone more horizontally, and ensuring the entire clavicle, including both the AC and SC joints, is visible. It's all about finding that sweet spot angle to separate the anatomy.
That's a real masterclass in getting around overlapping body parts. Okay, finally, let's explore how we get clear images of the scapula itself, that big flat shoulder blade on the back.
Right, the scapula presents its own challenges because it's thin and lies against the curved surface of the rib cage. The standard views are an AP and a lateral.
Okay, front and side. How do you do the AP scapula?
So the AP scapula, the patient is usually supine or standing. To pull the scapula away from the ribs laterally, the patient's arm on the affected side is abducted, moved out to the side, ideally to a right angle, with the elbow bent.
Pulling the scapula outwards.
Exactly. The central ray is aimed perpendicularly, about 2 inches below the coracoid process. And again, breathing is suspended to prevent motion blur. The goal here is to show the main body of the scapula, especially its lateral portion, free of superimposition from the ribs, with the scapula appearing fairly horizontal and not slanted.
Okay. And what about getting a side view, a lateral scapula? That must be quite tricky since it's so flat against the back.
It is. The lateral scapula view is quite versatile and requires careful positioning. The patient can be standing or seated, usually turned into a 45 to 60-degree anterior oblique position, so the side of their affected shoulder scapula is touching the image receptor.
So they're turned facing the detector somewhere.
Right. Posterior oblique positions can sometimes be used, but they tend to magnify the scapula because it's further from the detector. Now, the real trick here is how the patient holds their arm, because the arm position determines which part of the scapula is best demonstrated.
Ah, so arm position is key again.
Absolutely. To specifically demonstrate the acromionic coracoid processes, those top projections, the patient usually flexes their elbow and places the back of their hand on their lower back or posterior thorax.
Okay.
You have to adjust carefully to make sure the humerus itself doesn't overlap the parts of the scapula you want to see.
And to see the main body of the scapula in profile.
For the scapular body, there are a couple options. One is to have the patient extend their affected arm upward, flexing the elbow and resting the forearm on their head.
Arm up over the head?
Yeah. Or, alternatively, they can bring the arm across their upper anterior chest to grasp the opposite shoulder.
Arm across the chest. Why these positions?
Both maneuvers help rotate the scapula into a true lateral position relative to the X-ray beam. The goal is to get the lateral border, the thicker side near the armpit, and the medial border, the thinner side near the spine, perfectly superimposed on top of each other.
So they look like one single edge on the image.
Exactly. That tells you the scapular body is truly perpendicular to the plane of the image receptor, giving you a clear profile view.
And where do you aim the beam?
The central ray is perpendicular, aimed at the mid-medial border of the scapula, the edge closer to the spine.
And what are you looking for in a good lateral scapula image?
You want to see those lateral and medial borders superimposed, confirming a true lateral. You want minimal superimposition of the scapular body on the ribs, pulling it away clearly. And critically, no superimposition of the humerus, the arm bone, on the area of interest you're trying to evaluate, whether it's the body or the processes. And of course, you need to include the whole bone, from the acromion down to the inferior angle. It really shows how precise positioning unlocks diagnostic clarity for a bone that's naturally quite thin and potentially obscured.
Wow, what a deep dive that was into the incredible engineering, really, of the shoulder girdle and the sheer precision involved in capturing images of it. It's amazing. From, the subtle double curve of the clavicle we talked about to that really diagnostic Y of the scapula, we've unpacked how every angle, every patient position reveals vital information. It's clearly not just about pointing and shooting an X-ray.
No, not at all. It's much more involved. This journey truly highlights not just the anatomical marvel that is your shoulder, really a masterpiece of mobility and structure, but also the meticulous art and science behind medical imaging. Understanding these structures and the often quite clever techniques used to visualize them is absolutely fundamental for accurate diagnosis and effective treatment. It ensures that professionals can quite literally see what's happening beneath your skin.
It really makes you think about all the unseen work and the brilliant problem solving that goes into understanding and caring for our bodies, doesn't it? What aspects, maybe of your own body or even other complex systems you encounter, are you now curious to explore in more detail? Now that you maybe appreciate the depth of insight that can be uncovered with the right techniques, that's perhaps our challenge to you after this deep dive.
Absolutely. Until next time, keep exploring, keep questioning, and keep seeking those fascinating insights.